Hello and welcome to you all, and welcome to the National Drug and Alcohol Research Centre, the Symposium. Hello, welcome to you all here today. Firstly, may I start by acknowledging, paying my respects and gratitude to the traditional owners and custodians of the land where we sit, stand and meet on here today, tonight, tomorrow and always, the First Nations people, the Bidjigal people. And I pay my respects and give gratitude to my elders, past, present, and future emerging. And I bring to mind and light all their many endeavours and attributes and achievements into Australian society where they have been denied. Today we stand tall in all that we do and give to our country, Aboriginal Australia, and to your mammoth education learning institution that sits on sacred land that we share with you and all, your students from the many countries across the world. Thank you.
Colleagues, welcome. My name is Sean Emery. I'm the Senior Vice Dean for Research and Operations in the Faculty of Medicine and Health at the University of New South Wales. It's my great privilege and honour to be your Master of Ceremonies for Session 2 of the 2021 NDARC Annual Research Symposium. Can I start by acknowledging that I take this call or this meeting from the unceded lands of the Bidjigal people of the Eora Nation. I pay my respects to elders past and present, and I extend a particularly warm welcome to any of Australia's First Nations people who are participants in this important discussion on this day. Can I say good morning to colleagues in the Commonwealth of Australia, wherever you may be located? Can I extend a warm welcome to colleagues internationally at whatever time of day you are joining us? And can I invite you all to acknowledge the history of First Nations people in whatever location you're currently located. The session title for this morning, Session 2, is Global Patterns in Opioid Dependence and Treatment, Past History, Current Interventions and Future Actions. We have a spectacular panel of speakers, emerging talents from NDARC, established experts from the same community, and importantly, some powerful, important and significant voices from international colleagues on the topic we're here to discuss and learn about. I'll introduce those colleagues shortly. Some new housekeeping. It's a very different forum, of course. It used to be about the locations of the toilets and emergency procedures. It's now about how you ask questions. It's very novel for me, but we will go through the program as listed in the agenda for the session. And at various stages, there are opportunities for Q&A. Can I ask you please to use the Q&A prompt on the Zoom to post your questions, and I will try in the first part of the presentation this morning to moderate a discussion with our plenary speaker before handing over to other colleagues as we go through the process. So hopefully, as our plenary speaker is discussing his presentation, you will be prompting questions in the Q&A function on Zoom. Thank you very much for your help with that. Moving swiftly on, our first speaker this morning is Presidential Professor Emeritus David T. Courtwright, who is one of those delicious individuals who combines profound talent for writing and thinking and debating with a disciplined basis in history. And history, of course, is deeply important to informing the future. David's particular interests are extraordinarily eclectic and very broad, but he has a particular interest in the business of opioid dependence in the context of the US arena. And it is on that topic that we've invited him to speak and address a presentation this morning, Opioid Dependence and Treatment, Outlier Nation, my apologies, Opiate and Opioid Addiction Epidemics in US History. I'm very much looking forward to hearing David's distillation of that presentation title. And I'm delighted to welcome him to the Symposium for NDARC 2021. David, you're most welcome. Please proceed.
Thank you. And I would like to note that during the initial presentation, we had a few technical difficulties that had to do with bandwidth. And so what I have done is I have simply re-recorded this. So we'll have a nice clean version of the presentation. As Sean mentioned, my topic today is Outlier Nation, Opiate Addiction and Opioid Epidemics in US History. And before I get into the presentation itself, I just wanted to say that I'm going to be concentrating on medicinal opioids, or as they were once commonly known or referred to, opiates, the common name before the 1980s. I'm going to cover essentially the period 1870 to 2017. And a warning about a potential conflict. I have served and am continuing to serve as an expert witness in the national opioid litigation. Although I will say that most of what I'm going to be presenting this morning is based on research that I did decades ago and really doesn't have a lot to do with the current litigation. All right, so let me start with historiography, and I would point out to you that when professionally trained historians really got into this subject in the 70s and 80s, they tended to come to very similar conclusions. And the first conclusion was that, yes, indeed, the United States was unusual. There was a very serious problem relative to European nations in the late 19th century. David Musto, who published a book significantly entitled The American Disease in 1973, said you wouldn't find anything like this, or at least not to the same degree, in England or France or Germany or Russia or another European nation. I found the same thing, and like Musto, I did not attribute this to the Civil War. There was a school of thought that, well, gee, the United States had a uniquely bloody Civil War, and that might explain this opiate addiction epidemic. But, there are a couple of problems. One is that the per capita consumption of medicinal opiates really takes off in the 1870s, 80s, and 90s. And in fact, there's a tripling of per capita consumption of medicinal opiates between 1870 and 1890. And so that's after the Civil War. And then even more obviously, and I think more tellingly, most medicinal opiate addicts were native-born females who were treated or who had treated themselves for a variety of painful symptoms. And we also know from several studies carried out in the late 19th and early 20th century that the most common route to addiction of their male or female patients was morphine injection. And that was something that most people first encountered through a physician. All right, so predictably, this led to medical pushback. As early as 1870, doctors are beginning to warn against this new fad of hypodermic injection using morphine to treat chronic pain. It was understood that if you were dealing with trauma or some kind of short-term injury or surgery, that was one thing. Likewise, terminal diseases were, that was fine to give the patient morphine. But there's this pushback against treating everyday aches and pains with morphine. And here's a well-known example. This is a book by H.H. Kane, Drugs That Enslave, published in 1881. He cites not only U.S. sources for warnings about the hypodermic injection of morphine, but he also cites European sources, and he has a variety of disturbing case history, including the one you see on the right, which is a woodcut, which is made from an actual photograph of a dying male nurse at Bellevue Hospital in New York, who had self-administered morphine, had become addicted, His body became covered with abscesses, and he is now in the final hours of his life. So what was the significance of these early professional warnings, which, as I say, began as early as the 1870s? Well, first, we all need to keep in mind that this debate over the use of these powerful prescription narcotics to treat chronic non-malignant pain is not novel. It didn't begin in the 2010s and culminate in the CDC's, the US CDC's recommendations for revised prescribing guidelines in 2016. No, the story is much older, and in fact goes back 150 years. And indeed, one of the really surprising, even scandalous aspects of what's happened in the United States in the last 30 or 40 years is that this very substantial body of historical and statistical information on the risks associated with treating chronic non-malignant pain with opiates was ignored when the practice was revised at the end of the 20th century. This historic debate drew attention not only to addiction, but also to the risk of overdose, infection, which was frequently mentioned, problems with newborns, crime, loss of moral character. There were a lot of concerns that were expressed again in the early 2000s when the problem returned to the United States in a big way. In the late 19th century, this debate was resolved in favor of the conservative position, that is the therapeutically conservative position, which grew stronger over time. And it was institutionalized. So not only were people writing articles and books about the dangers of administering opiates in chronic pain, but these warnings were preserved and cataloged, and eventually they were institutionalized in medical texts and curricula. So that leads to a very interesting and important question, which is, why did it take the U.S. medical profession so long to reverse course? So remember what I said earlier, the warnings start around 1870, but per capita consumption keeps rising, and in fact, it peaks around 1895, and then it starts to go down. And what explains this lag? And the best explanation, in my view, is really the poverty of the American medical profession for most of the 19th century. Doctors were poorly educated for the most part. There was not a lot they could do for most diseases. There were too many doctors. They were economically competitive. They were tempted to resort to opiates for the symptomatic treatment of pain as a way of winning over patients. It was mainly, I think, the state of the medical profession that explains more than anything else why this new technology, the injection of morphine, was so overused and with such bad results. I should add to that doctors also got a break toward the end of the 19th and the beginning of the 20th centuries because other analgesics became available to them, not only to them, but eventually to their patients who, after 1915, could simply buy aspirin over the counter. Initially, it was a prescription drug. The point is, it was a non-opioid prescription drug. And it was something doctors and patients could use for neuralgia or rheumatism or neuritis, lumbago, problems that had previously been treated with opioids. This isn't to say that aspirin is without risks, but they're considerably less than treating someone with a powerful opiate like morphine. So that this also helped. And I should add that the conservatism about opiates was not confined to the medical profession. So the public was also becoming increasingly wary of opiates, and this was reinforced in popular culture. A famous example, in 1956, Eugene O'Neill's great play, A Long Day's Journey into Night, was published posthumously, and it was picked up immediately, published. 1 million copies were sold. It won a Pulitzer Prize. It was performed on Broadway to great acclaim, and ultimately made into a popular motion picture starring none other than Katharine Hepburn, who plays a character called Mary Tyrone, who's modeled on Eugene O'Neill's own mother, Ella Quinlan O'Neill, who was what? Who was a morphine addict. And she had become addicted, as she says in the play, through the ministrations of a cheap hotel doctor. This was following the painful and difficult birth of her third son, her third child, Eugene, the playwright. So there are many other examples I could give you. This will suffice. Not only physicians, not only government regulators, but American consumers became increasingly wary of opiates, unless, of course, we're talking about a terminal condition. All right, so let's talk about the epidemiological consequences of these changes in attitudes. Let's cash this out. And I think this important point to be made here is that primary prevention works. Okay, when you restrict supply, in this case, the supply of prescription opiates, and also opiates in patent medicines and other forms of self-medication, you get a reduction in addiction prevalence. And this happened because of a kind of demographic tailwind. I mean, if you think about it, the people who had been addicted in, let's say, the 1880s or the 1890s, many of them were sick, aging, and they continued to age over time. And they basically either quit or eventually died. And as they died off, they were not replaced by new iatrogenic addicts because the profession had, by that point, by the early 20th century, become more conservative. And so the old addicts, this large cohort of old addicts, are dying off. They're shown in white in this particular diagram, and they're not being replaced. Now, there was also what might be called a hard core of non-medical addicts, and these consisted mainly of individual white underworld and also indentured laborers, Chinese indentured laborers who had brought the practice of opium smoking with them to the United States. And that continued, and that was regarded as a vice. Same thing was true in Australia. Opium smoking was certainly regarded as a vice, as it was in the United States. There was a change over time. Non-medical addicts went from opium or morphine combined with cocaine to heroin, but still, it was still the same basic phenomenon in the United States, and it did not shrink in the same way that medicinal opiate addiction shrank in the early 20th century. So the consequence of this is that by 1935, the United States is no longer an outlier nation. You have narcotic addiction concentrated in the underworld. It's essentially non-medical, or mainly non-medical in origin, I should say. And the outlier nation by the, say, the late 1930s, early 1940s was China, which consumed 90% of the world's opium. And so things had gotten back to normal as it were in the United States until they didn't. And what happened was, first, there were two heroin epidemics in the United States. A small one in the late 40s and the early 50s, when the supply of heroin resumed in the country after World War II. And then there was a big one in the late 1960s and the early 1970s. That was the crucial one in terms of, once again, expanding the prevalence of opiate addiction in the United States. And of course, prompted very strong political reaction, Nixon's drug war, and all of that. And I remember Robert DuPont, who became the first director of NIDA, saying that when he was coming up in the late 60s and the early 70s, which was when he began his career studying addiction, he said that, in my time, it wasn't the drug problem, it was the heroin problem. And that's how most people thought about this in, say, the early 1970s in the United States. Well, it continued to be the heroin problem. And I spent a lot of time when I prepared the second edition of Dark Paradise working in the DEA archives and DEA library and studying estimates of heroin prevalence and so on. And when I published the second edition in 2001, I decided that basically what had happened is that, in terms of prevalence anyway, the country had remained on a high plateau, despite losses from AIDS, despite the aging of that 60s and 70s cohort. Enough new heroin addicts had come in that overall the country still had around 600,000 heroin addicts. And so I, updated my chart and published my book and was very pleased with myself. And then darn if the virtually at the same time I published the book, I don't start reading about OxyContin abuse and addiction in the newspaper, or I start seeing stories on television news about this new drug, which is a prescription opioid. And I'm astonished by this. I'm thinking, wait a minute, that's so 1880. What is? Come on, prescription opioids. We're over that. Except unfortunately that we weren't. And if you were to draw another circle about 20 years later, you would discover that it would be approximately 4 times as large. And there, according to NIDA, there would have then been about 2.4 million opioid addicts in the United States, and the vast majority, 1.9 million, were using prescription opioids, and only about 586,000 were using heroin. I remember in the city in which I live, Jacksonville, Florida, sometime around 2010, a nurse gave an interview with a local media outlet in which she said it was rare in her methadone program. She worked as a nurse administrator for methadone. She said it was rare to admit somebody who was a primary heroin user, or identified that as their primary drug of use. She was mainly seeing prescription opioid users, which was a common thing in U.S. treatment programs in that period, 2008, 9, 10, 11, 12, this big swing to prescription opioids. Now, virtually everyone agrees that this increase in prescription opioid abuse and addiction and overdoses was tied in to a big increase in prescribing. Here you see data for the critical period from the late 90s to up to about 2010. And the question is, why did this happen? And it's both a medical mystery and it's a historical mystery, because doctors had been conservative about opiates for most of the 20th century. They'd learned their lesson. They'd gotten burned in the late 19th century and had, at least with respect to opiates, been fairly cautious in the 20th century. Now, admittedly, with respect to diazepam and with respect to amphetamine and sedatives, there were other kinds of problems associated with iatrogenic addiction. But when it came to opiates, they didn't experience anything like the disaster of the late 19th century. So what happened to change attitudes? And in particular, I think the key question is, what did the pharmaceutical industry, especially those involved in manufacturing and marketing opioids, what did they do to change medical opinion? And the answer that I would give to that is that, and this may come as a bit of a surprise, they didn't invent revisionism. And by revisionism, I simply mean this position that old conservative attitudes are bad, new liberal attitudes towards prescribing for chronic non-cancer pain are good. This idea was cooked up by a handful of medical academics and strategic institutions who had initially been concerned with the undertreatment of cancer pain, which was a fair issue in my view. But they decided to take the point and push it harder, and they, beginning in 1980, started advocating the liberal prescribing of opioids for chronic non-cancer pain. That idea was co-opted, especially by Purdue Frederick, and especially from 1984 on. And around this idea, the industry built this elaborate campaign focused on such revisionist themes as pain under treatment as a public health crisis, or opiophobia, which meant that doctors were wrong to think about, to overstate the dangers of prescribing, especially with these new controlled release formulations, the concept of pseudo addiction, which meant that, if the patient displays tolerance and they need more and more of the drug, that's not really about tolerance. That's because you haven't adequately titrated the dose to take care of their pain, etc. So you get all of you get this package of revisionist ideas combined with very intense lobbying to persuade medical institutions to embrace more liberal prescribing for chronic non-cancer pain. And that effort is successful, and it's also emulated. After OxyContin becomes a blockbuster drug in 1996, other companies jump on board. They in American football, there's a particularly egregious foul called the dog pile, in which someone tackles the ball carrier, and then the second, third, fourth, fifth, sixth, seventh, eighth, 9th, 10th, 11th member of the defense jumps on top of the fallen ball carrier, which, to my mind anyway, is pretty much what happens with the opioid crisis. Lots of people emulate Purdue. I should say lots of companies emulated Purdue. And so you get all of these new and powerful drugs, Senta, Havana, and so on. And the problem used to get worse despite the public relations that I'm pouring out in 2000 and 2001. So as a consequence of this everybody piling on phenomenon and more aggressive revisionist marketing of prescription opioids, which of course increases the supply, you get an increase in what I call direct and indirect prescription opioid iatrogenesis. So this is for the US, late 20th and the early 21st century. But I would ask you to look carefully at the slide because I think it's universal. I think that you can really extrapolate this heuristic onto virtually any situation, any society in which you have both licit and illicit supplies of opiates. So there's something like universal agreement among people in the field that there are some people who are at high risk of addiction, moderate risk, or average risk, and some people who are at low risk. Now, there's a fierce debate about why that is, whether it's genetic, whether it's early childhood trauma, whether it's mental illness, anxiety, bipolar disorder, and so on, whether it's abuse of alcohol and other drugs. There are many theories as to why some people are more susceptible than others, but there is agreement that is the case. And there's also broad agreement that whatever your level of genetic or environmentally induced susceptibility might be, you won't get addicted if you're not exposed to the drug in the first place. All right. And so what this revolution in prescribing did is it exposed more people directly. The doctors were treating their painful symptoms with opioids or writing prescriptions. Some percentage of those people, probably on the order of 10, 12, 15%, something in that range, went off the rails and became full-blown addicts. But in addition to that, there was increasing diversion. All right, so with this big increase in supply, you get pilfering from medicine cabinets, you get people selling drugs on the streets, you get people sharing them with friends. And so this part of this illicit supply, this big increase in illicit supply, actually ends up in the illicit market, and people get exposed that way through non-medical means. So both of these things are happening in the 1990s and early 2000s, and result more and more people of varying susceptibility are being exposed. So once again, the United States became an outlier nation. These data are from Keith Humphreys. They appeared in the Washington Post in 2017. He basically took tabular data from the INCB and put it in graphic form, but you can see that the United States was consuming 6 times as much per capita in terms of opioids, prescription opioids, as a country like Portugal. So that which had happened in the late 19th century happened again, unfortunately, in the late 20th and the early 21st century. And essentially, the story is one of history repeating itself, but in a bad way. So those are my formal remarks, and now I would be pleased to take your questions.
David, on behalf of us all, thank you very, very much for setting this session up so elegantly and comprehensively. It's a vexed issue and an extraordinarily challenging one, as you've indicated, with a powerful history behind it. I've encouraged people in the chat to forward questions, and I'll be monitoring that portal as you and I talk. But I do encourage our audience this morning or this evening, wherever you're located, to give us your questions to present to David. What I might do is try and set this up in my typical provocative way. David, your thesis is that perhaps the US is an outlier, and that may well indeed be true. But what do you believe prevents the same kinds of outcomes of concern, more or less, from happening elsewhere in the world that is the point of origin, if you like, for the situation that you are seeing in the US? What is so different about the way society works in Europe or Australasia or Africa or some other part of the world that we can learn from, in your view?
Well, the short answer to that question is that the pharmaceutical industry in most other countries has a great deal less power and influence than was the case in the United States. When I say the United States is an outlier nation, one of the things you should take away from my presentation is that we were, we weren't, and then we were again. This is a case of history repeating itself in a bad way. So we were an outlier nation in the late 19th century, largely because of the poverty of the American medical profession and its inability to really something about most chronic conditions. By the mid-20th century, when the problem had become essentially a heroin problem, the United States, like most other industrialized nations, you need to know that in 1940, 80% of the world's opium was consumed in China. And there were countries like Egypt, which had, even though the population of Egypt was far smaller than the United States, had far more narcotic addicts than the United States. So we, in relative terms, we were more or less normal by the mid-20th century. And then we had this influx of heroin addiction, and then pharma piled on. And pharma tried to penetrate the chronic non-cancer pain market in the 40s and 50s and was turned back by federal regulators. That's a fascinating story. It would be going too far in the weeds to try to tell it here. But they had tried before and they were turned back. But they were able to penetrate that market in the 1990s and early 2000s, owing in part to their marketing and political influence. And also, and I think this is fascinating, they used cancer pain as political cover. So a lot of the early propaganda on behalf of opioids and chronic non-cancer pain actually appears in conferences and books that have the title Opioids and Cancer Pain. So there's a direction here. Everybody comes out of the closet and wants to do just to get OxyContin approved for severe to moderate chronic non-cancer pain in late 1995. Then everybody jumps onto the bandwagon.
David, thank you. So we've got some questions coming through. Thank you to all of those that are posting them. The first one's from Stephanie Todd. Stephanie, thank you. The question is, can you see, David, any way to prevent the kind of tactics used by pharma going forward into the future?
That's a very good question. You know, one way to think about the opioid litigation is that it addresses a government failure. No, that's too strong. The CDC didn't really lay down the law and get serious about revising prescribing guidelines until 2016. The industry is so powerful. The industry delayed for 2.5 years the upscheduling of hydrocodone from Schedule 3 to Schedule 2 under the Controlled Substances Act. That was just sheer political power. There's the whole story of what in the United States is called the Marino Bill, which was a way of using the power of the Drug Enforcement Administration to immediately shut down distributors and other pharmaceutical entities that were irresponsibly distributing opioids. I guess the answer to the question is, what could you do about this? Is rein in the power of the pharmaceutical industry. Although, honestly, I think now most of the discussion about the abuse of pharmaceutical power in this country is more focused on drug pricing than it is on the overpromotion and encouraging the overprescribing of opioids. Because, and you all are probably way ahead of me on this, you realize that since 2017, the opioid epidemic in the United States has moved into another stage. It's now more about heroin and fentanyl than it was, say, back in 2010. And so I guess the horse is out of the barn.
David, thank you. A follow-up question from Lee that I think pushes on the responsibility of the clinical communities around the topic you've discussed with us. The question is it a given that doctors overprescribed opioids when other drugs could have been a more appropriate choice?
It's not a given. Let me, certainly physicians were susceptible to pharmaceutical industry influence, but I would add something important to that. It was mainly younger physicians. So I have spoken to a number of doctors who hated the changes they saw in the liberalization of opioid prescribing in the late 1990s and early 2000s. And they hated the new emphasis on pain and how patients have to be kept happy by treating their pain symptoms in the hospital, which often meant giving them opioids. There was people who had been trained earlier in a more conservative era. I think that the biggest impact was probably among the younger or mid-career physicians, and I don't really blame them. I think medicine is very hierarchical as a profession. I think people pretty much do what they're trained to do. And when the training changed, when the revisionist ideas penetrated medical curricula in the 1990s and early 2000s, you got a lot of younger doctors who thought, yeah, historically, the dangers of using prescription opioids have been overstressed, and we can safely administer these drugs in a much wider variety of situations than was thought possible in the past.
David, a question here from Malcolm Dobbin. Malcolm, thank you. You didn't, in your presentation, touch on the issue of opioid replacement programs or interventions available, and methadone programs are one such example that there's familiarity, certainly in Australia. Could you perhaps describe why it is the experience with methadone in the US seems different from elsewhere in the world, and why it seems to be relatively inaccessible in the US setting?
Oh gosh, the answer to that question is that the United States has gone through a 40 or 50-year culture war in which drug policy has become unusually politicized. And that's been true for a long time. Back in the 1980s, I interviewed Vince Dole, Marie Niswander, Bob Newman, the people who basically created large-scale methadone maintenance in the United States. But I also interviewed the leaders of the so-called second-generation therapeutic communities, people like Dr. Mitch Rosenthal or Judy Ann Denson. And what you see is at bottom, it's not just about double-blind studies of methadone and how there is a moral dimension. There's always a moral dimension, which is that if you're still taking an opioid, you're a failure. And that gets mixed up with religious attitudes. And there's this perception by the early 1980s that methadone is essentially some kind of a liberal plot, that the people who are in favor of methadone maintenance aren't really serious about the drug war and re-stigmatizing drug use. And that's true. It's true. The people who were in favor of methadone maintenance wanted, among other things, to destigmatize opioid addiction to get people into treatment. So the values and the worldviews of the people in these different communities were at odds with one another. And I would say, not as a medical historian, not as a drug historian, but as an American historian, you cannot understand about the drug mess in the United States in the late 20th and the early 30s, and understand that it was wrapped up in this larger culture war that has unfortunately disrupted and disfixed.
David, thank you. Now, if I understand my instructions from the Politburo correctly, we were to finish promptly at 10 minutes past the hour, which is where we are right now. There are much more in the form of questions than we've been able to discuss with you as a conversant. And I wonder if we might ask the organizing group to perhaps see if we can raise the questions with you offline and generate responses in some way. I can't make a promise that that's possible, but we'll certainly investigate and try. David, can I thank you on behalf of NDARC, the University of New South Wales, and the audience with whom you've discussed your views and data this morning for a particularly splendid journey of really important stuff that we all need to be much more familiar with. Thank you so very, very much, and hope you can stay with us for the rest of this evening session with you on the East Coast. My final task.
And thank you. And
please, David.
Oh no, I was just gonna remind all of the participants, if you're involved in this, don't try to send a 3 meg file halfway around the world. That was the other lesson that we learned this evening. So thank you for your help in bailing me out.
The very least we could do, it was terribly important. So my final task for the session is to hand you over to my colleague, Scientia Professor Louisa Degenhardt, from the National Drug and Alcohol Research Centre. Louisa, over to you. Thank you very much.
Thank you very much, Sean, and thanks for the wonderful presentation, David. I will go now to present a series of poster presentations that have been drafted by various researchers at NDARC, and this will go for about 10 minutes, and then I will be speaking up to that. So thanks very much.
Hi, I'm Samantha College and I'm a PhD candidate at the National Drug and Alcohol Research Centre. Thanks so much for your interest in this work. We conducted a study that aimed to look at the impact of opioid agonist treatment on hospital separations for injecting-related diseases. It was strictly non-viral diseases, so included bacterial and fungal infections like abscess wounds, endocarditis, sepsis, and so on. We used a large linked data set with a base cohort of over 47,000 people who were prescribed opioid agonist treatment between 2001 and 2017 in New South Wales. We estimated the crude incidence rates of hospitalisations for injecting-related diseases overall by year and by treatment status. We created a data set with discrete observation periods so that we could include time-varying confounding variables like age, recent hospitalisation, recent incarceration and mental health treatment into the GEE model. We calculated incidence rate ratios adjusting for these factors so that we could compare the rate of hospitalisations in the different treatment statuses, which we defined as the first 4 weeks of treatment, the remainder of time on treatment or treatment retention, and time out of OAT. We found that the incidence of any injecting-related disease almost doubled over the study period, and this was largely driven by increases in skin and soft tissue infections and sepsis diagnoses. We are seeing similar trends in other parts of the world. This wasn't a total surprise, but is certainly cause for concern. And we did find that retention on OAT was associated with a reduced risk of being hospitalised for an injecting-related disease after adjusting for potential confounding variables. And the protective effect of OAT was largest for endocarditis and septic arthritis presentations, where the reduction in risk was about 25%. So this is really critical for places where OAT coverage is relatively low and cases of injecting-related endocarditis are increasing, which is the case in the United States in particular. However, this increasing trend that we are seeing is really concerning, especially here in New South Wales, where OAT coverage is relatively good. It may be that we're seeing the consequences of increased methamphetamine injecting among people on OAT or people who are opioid dependent, or it might be in an increased threat of antibiotic-resistant bacteria. So either way, it is something that we need to better understand if we are going to prevent these harms more effectively. Thank you so much for listening.
Policies to address opioid-related harms include strategies to reduce opioid prescribing for both new and ongoing management of pain, including restricted prescribing indications and quantities, and prescribers having to obtain government approval for long-term opioid treatment. But there's concern that people with chronic non-cancer pain may be adversely affected by opioid restrictions and policies. And there's also mounting evidence that involuntary opioid tapering and cessation may be associated with adverse events, including overdose and mental health crises, leading to death. In this study, we aim to describe difficulties obtaining opioid prescriptions among people who are prescribed these medicines long-term for chronic non-cancer pain. So in the Pain and Opioids in Treatment study, 1,514 Australians prescribed opioids for chronic non-cancer pain were interviewed annually. And in 2018, during Year 5 interviews, 861 participants who reported using an opioid in the past 12 months were asked about difficulties obtaining opioid prescriptions. You can see some of the difficulties here, and the rest are reported on our poster. 1 in 3 participants reported at least one difficulty or challenge, including prescriber access-related difficulties and involuntary opioid tapering or cessation. Logistic regression was used to assess associations between difficulties and participant and treatment characteristics. You can see here that reporting a prescriber access-related difficulty was associated with younger age, as well as with meeting the criteria for pharmaceutical opioid dependence in the past 12 months. involuntary tapering or cessation, was associated with lifetime substance use disorder, and that was to do with any substance, and higher daily opioid doses. So 1/3 of participants using opioids for chronic non-cancer pain reported experiencing difficulties obtaining ongoing opioid prescriptions. The risk of opioid-related harms must be balanced against clinical need, as well as the risk of adverse outcomes associated with tapering. And there's a need for policymakers to consider both the intentional and the unintentional policy impacts on people prescribed opioids for chronic pain. Thank you.
Hi, my name is Nikki and I'm here to talk about my poster, Retention of Opioid Agonist Treatment Prescribers. This is one of the outcomes from the Opioid Agonist Treatment Safety Study. Now, the OAT Safety Study is a retrospective cohort study of all people prescribed OAT in New South Wales between 2001 and 2018. It's a data linkage study, so it's been linked to several administrative data sets. And the main aim of the study was to better understand the risk of adverse outcomes. Now, this was the first time we've received data on the clinicians prescribing OAT. So we wanted to assess the trends in OAT prescribing activity and also assess the characteristics of OAT prescribers that stopped prescribing OAT. Then we wanted to profile the top 20% prescribers based on an annual snapshot of their caseloads. So here we can see the number of unique prescribers annually from 2001 to 2017. So in 2017, there were 2,000 unique prescribers of OAT, but actually there were only 1,000 that were actively prescribing OAT in 2017. So between 2001 and 2017, we've lost half of our OAT prescribers. Now, the overall cessation rate increased from 3% in 2001 to 12% in 2017. Now, the top line represents the prescribers of OAT with a tenure of prescribing OAT of 5 years or less. And that's got the highest, this group has the highest cessation rate. When we look at Pareto's principle and apply the 80-20 rule, the top 20% prescribers cared for 87% of people on OAT in 2017. Now, the median tenure of this top 20% was 17.5 years, where the median tenure of the bottom 80% was just 5 years. So the conclusion from this study is that OAT prescribing is concentrated in a small group of mature prescribers, and new prescribers are not being retained. And this puts the OAT system at risk. We need to understand better the challenges behind retaining new prescribers. Here's a list of my acknowledgements. And here's a link to the OAT Safety Study webpage, where there are further links to published papers around this data. Please check out my poster. Thanks for listening.
So thank you very much to the poster presenters for their series of presentations from NDARC work. Just before I begin, I'd like to acknowledge the traditional custodians of country throughout Australia and recognise their continuing connection to land, waters and culture. I'd like to pay my respects to elders past, present and emerging. And this morning I am speaking from Gadigal land. I'm summarising a range of different studies today, and I'd just really like to acknowledge there's a very large group of researchers from NDARC and collaborators from across Australia and internationally who've contributed to the work that I've summarised here. And this has really been, the product of decades of work. Very importantly, I'd like to acknowledge the people who have been willing to share their experience of drug use and both the positive and negative consequences of their drug use with us across these studies, because much of this work would not be possible if they did not feel comfortable doing so. The work I'm summarising here has been funded from multiple sources, so I'd just like to acknowledge those. And I'd just like to disclose that in the past 3 years, I've been an investigator on unpaid educational grants for the study of new opioid medications in Australia. Just given David's presentation, I thought it might be a good idea just to give a very brief note on some trends in opioid markets in Australia. I'm not a historian. This is going to be very brief, but I just thought I would touch on a few features of what's happened in terms of heroin and other opioid markets in Australia, because some people in the audience might have had questions given what David presented on. So very briefly, further into the past, heroin use really started being introduced into Australia, it's thought, from the late 1960s. And part of the prompter for that was actually US Army people on rest and recreation visits to Australia from the Vietnam War. And heroin was noted to be being used in the cross and fairly limited geographic areas from then. Throughout the 70s, it was fairly small scale. There was fairly small scale heroin use throughout the 1970s, but from the 1980s, for a range of reasons, there were increases in the number of people who are opioid dependent. And you can see some of the work that was done to estimate the number of people who are heroin dependent on the bottom right-hand side of this slide. You can see those increases from the late 1970s. But it was in the 1990s that there was a large increase in the scale of the heroin market into new geographic markets within Sydney, external to Sydney. We saw expanding use geographically across Australia. And as you can see in the bottom left-hand figure, the opioid overdose rate increased dramatically. Throughout this period and with government recognition that there was concerns around what was happening around illicit drug use and harm, the illicit drug reporting system was first trialled in Sydney, New South Wales in 1996, and it was gradually scaled up to be the national system from 2000. And what that found, as did other research that was conducted by NDARC and other researchers, was that heroin was the most often injected drug among people who injected drugs. Other work conducted at NDARC, for example, by Lisa Ma, also identified that there were new cohorts of people who were using heroin, particularly in southwest Sydney, and including the initiation of heroin use via smoking with younger people. There was a lot of concern around the increases in opioid overdose, and in New South Wales there was an expansion in methadone treatment across this period. Presentation on Australian heroin markets wouldn't be complete if I didn't mention the Australian heroin shortage. This occurred from early 2001, where there was a substantial disruption in supply at the street level. People were finding it very difficult to obtain heroin, whereas it had been very easily available before. We saw heroin purity halving at the street level and price doubled. This disruption was sustained and it was observed throughout the country, but the most established and widely available heroin markets were in Sydney, New South Wales and Melbourne and Victoria. We conducted a range of studies looking at this, and we were able to observe reductions at the population level in heroin overdose, reductions in injecting drug use, and in new hepatitis C notifications. We also saw increases in use of psychostimulants. It depended which in cocaine injection in Sydney, amphetamine injection in other jurisdictions. We saw increases in risky injecting, and there were reports of drug-induced psychosis, particularly related to that increase in psychostimulant use. In New South Wales, we saw that this reduction in availability of heroin saw increases in re-entry into opioid agonist treatment for people who had previously entered treatment, so for people who had an established connection to treatment. There were some increases in treatment for psychostimulant use, and there were also shifts in the way that drug distribution was conducted. Previously, it had been quite overt and on the street. It shifted to being much more covert in manner. And there are also shifts in the drugs sold. So people who were previously dealing heroin shifted to dealing cocaine and amphetamines. We also conducted a critique of the potential explanations of this heroin shortage, which I won't go into here, and the reasons for the disruption in supply remain debated. So from the 2000s, we did see increases in pharmaceutical opioid use as were observed in the United States, not to the extent that has been observed in America though. We saw, as you can see on the bottom left-hand graph, this is opioid-induced deaths and by opioid type. This top line here is all opioids, and you can see heroin dropping dramatically with the heroin shortage. This is natural and semi-synthetic opioids, which includes morphine. Some of those deaths may well be heroin, but what you can see is that those low levels stabilised, but they have since increased. We've also seen increases in overdose deaths due to pharmaceutical opioids. What you can see on the right is data from the illicit drug reporting system, so people who inject drugs regularly. And this is across Australia, and what you can see is that heroin remains the most commonly injected opioid. There is some evidence that is increasing in recent years. These data go up to 2020. Rachel Sutherland and others will be presenting on the findings for 2021 at the session of the symposium tomorrow morning. So I'd encourage you to attend to find out the latest trends there. What you can also see here is the increases across the 2000s in injection of oxycodone, which then fell off after the introduction of a tamper-resistant formulation of the drug. Right down the bottom there, you can see injection of fentanyl. This is not illicitly manufactured fentanyl, it's fentanyl patches, and you can see that remains comparatively low. So for the remainder of this talk, what I'm going to be summarising is a series of studies that we have conducted over the past 10 or so years that use data linkage to examine health and other outcomes among people who are opioid dependent. And what I'm just going to do, I know we just had a couple of posters using some of the data from these studies, but I might just give a bit of a summary of what it is that we've been able to use here in New South Wales. So the top orange line there is data on people who have entered opioid agonist treatment. Now, all of these are administrative data sets. None of them are perfect for the purposes of research, but we have reasonable confidence in all of these data sets that they are pretty high quality. So for opioid agonist treatment, when someone enters methadone or buprenorphine, their prescriber needs to obtain an authority to prescribe. And that is maintained at a central database within New South Wales Health. And there's information on whether or not they're receiving methadone or buprenorphine. And then when someone leaves treatment, there's also a notification that they've left. So what that allows us to do in a completely de-identified manner, if we link across different data sets, is to look at what is happening for someone when they are going in and out of opioid agonist treatment, when they're switching between methadone or buprenorphine, and when they're receiving opioid agonist treatment from different settings. So across a variety of studies, we have linked this data on opioid agonist treatment to data on mortality. We've linked it to people's hospitalisation and emergency department visits. We've also focused on people's engagement with the criminal justice system, so their charges and also whether or not they've experienced incarceration. We've also looked at infectious disease and cancer notifications. So I'm just going to give you a summary of some of the things that those data linkage studies have allowed us to examine, and then I'll briefly summarise what we found when we've done that. So as I mentioned before, because we've got data on people's time in and out of treatment, we have over time conducted a number of analyses of retention in opioid agonist treatment. As you heard from Tom, retention in treatment reduces mortality risk, but is also important in a range of other outcomes. It's also allowed us to look at the characteristics of OAT prescribers, as Nikki presented, and to look at changes in the profile of people who are prescribing OAT in New South Wales over time. We've also looked at health outcomes for people who are opioid dependent. So what is their risk of cancer, infectious disease, overdose, and other outcomes? We've looked at their engagement with the criminal justice system, use of various health services, and then what we've done and are continuing to do is to look at whether or not there is evidence for some impact of OAT on a range of different outcomes. And finally, using all of that population level data and all of the evidence that we've obtained on that, as Anik Borquez will be presenting later in the session, we've used those real world empirical data and parameters to model what we think the population level impact of OAT provision might have been in New South Wales over the past 20 years. So just to give you a brief summary of the characteristics of people who have received OAT since 2001. You can see that the number of people in treatment is now around 20,000 as at, well, it was at the end of this study in 2018 across the state as at January 1st each year. You can see the increases over time in the number of people who are receiving buprenorphine. It was first introduced in 2001. At treatment entry, about 1/3 of people who were entering treatment were women. They were a median of 32 years. 1 in 5 were Aboriginal or Torres Strait Islander descent. Half of the people who had received treatment post 2001 had already received it in the 1985 to 2000 period, and 1 in 4 were from regional New South Wales. As you can see, during the study follow-up, we had really high rates of people engaging in mental health treatment, visiting the emergency department, being hospitalised, and very high rates of engagement with the criminal justice system. So just to look at some of the work that we've done in terms of the trends in retention. So between 1,300 to 2,200 people enter treatment for the first time each year. And so this is work led by Kriana Barat, and this shows that there has been improvements. If you look at the orange bars, the top over here, over time there have been real improvements in retention, particularly for buprenorphine. And that has been sustained whether or not you're looking at retention at 3 months, 6 months, or 24 months. Buprenorphine is also increasingly the medication that is being used when people first enter OAT. It was 1 in 4 in 2001, but now it's almost 2 in 3 people who start OAT at the end of this study period were starting on buprenorphine. Nikki presented on the analysis looking at the OAT prescriber population. We thought this was a really important piece of work because it really speaks to, you know, structural and systemic issues related to the OAT treatment system in New South Wales. There has been a steady increase in the number of people who are stopping opioid prescribing. The people, as Nikki mentioned in her presentation, those who are ceasing had smaller numbers of clients and had not been prescribing for long, but they were the newer OAT prescribers. So prescribing is increasingly being concentrated in small numbers of very high volume and very long tenure prescribers, which really speaks to concerning issues on the horizon in terms of the sustainability of the system once people reach retirement age. Another thing that, that Nikki's work also found is that when someone ceased prescribing, the people that they had been prescribing to were at very elevated risk of actually dropping out of treatment. So that's a further issue of concern. So just to give you a couple of summaries, some of the things that we found in terms of health and other outcomes. Between 2001 and 2017, people who had entered treatment at any point in that period, 1 in 6 had been hospitalised for a non-fatal overdose during that time. And we estimate that people in this cohort, remembering from what Samantha College presented, this is around 47,000 people. This cohort accounted for 1 in 5 opioid non-fatal overdose hospital stays in New South Wales, 1 in 10 non-fatal overdoses for sedatives, and 1 in 8 non-fatal overdoses for stimulants. Some earlier work that we did focusing on engagement with the criminal justice system found that 3 out of 4 in the cohort between 1993 and 2011 had at least 1 criminal charge. A lot of these were property offences. There are a substantial number of traffic offences and violent offences. The cohort accounted for around 1 out of 8 of all court appearances in New South Wales, and the estimated cost of this was over $300 million. So this engagement with the criminal justice system is costing a lot of money. And when you look at the costs of incarceration of this cohort, of whom 4 in 10 had experienced incarceration over a 12-year period, the costs of incarceration of this cohort we estimated were around $3 billion. And there are real opportunities here to reduce the extent of this engagement with the criminal justice system. And there are many adverse consequences of having a criminal record and of being incarcerated. And it was clearly vulnerable in both respects. Work that we looked at in mortality, we found that on average among people who died in this 1985 to 2005 period that I've shown in the figure here from some earlier work, on average, people who died lost 43 potential years of life through that death. And that was particularly the case because of the real concentration of drug-related deaths in this cohort, which you can see in the dark purple there. Opioid-related deaths accounted for 40% of all deaths in this cohort across this period. So there was a massive opportunity to really address and reduce this important cause of death. But there are other important things that we found in this work. Suicides accounted for 1 in 8 deaths in this cohort, and we also documented that liver-related deaths were increasing over this period, and 3 in 4 of those liver-related deaths were due to viral hepatitis, clearly speaking to the important health consequences of infection with hepatitis C and the importance of increasing treatment. And finally, looking at the impact of OAT on a range of outcomes, as was summarised in the meta-analysis that Tom presented in his poster, we found consistent with other studies that mortality is halved in treatment compared to time spent out of treatment, particularly for opioid deaths, suicide and unintentional injuries. Mortality risks were elevated during the first 4 weeks in and out of OAT, the first 4 weeks in largely being for methadone. And there was a difference between methadone and buprenorphine in that induction period, where the mortality was 5 times higher for methadone mortality than it was for buprenorphine. But that difference does not persist once people have been inducted and are stabilised on treatment. We also examined, we're fortunate in New South Wales to have OAT available in prison for people who are opioid dependent. And we used our linked data because we could track people in and out of treatment, but also we knew when they were coming in and out of incarceration to look at whether or not people were receiving treatment during their incarceration and whether or not once they left incarceration, if they received OAT once they left. As you can see on the left-hand side, we found that the hazard of death was 74% lower during time spent in OAT while incarcerated. We adjusted for a wide range of confounders, which had no effect on the crude hazard. And what you can see is there's also a particularly large effect in the first 4 weeks of incarceration, which are a known very high risk period for people to die. Leaving prison is also a very risky period, and we similarly found in the first 4 weeks of leaving incarceration, if you were in OAT, your risk of dying was 75% lower during time spent during incarceration. It was also important that you had been receiving OAT during incarceration. Only in the first few days. It was really important in terms of looking at reductions in risk that people entered OAT following leaving prison in terms of looking at reduced mortality risk. This is looking at the impact of OAT on fatal overdose, but also non-fatal overdose. So there's been a lot of emphasis looking at mortality, but we wanted to look at what the risks were in terms of hospitalizations for non-fatal overdose. for both opioids and other drugs. And we found clear evidence that being in treatment is protective against all types of overdose. This is hospitalizations for non-fatal overdose, as well as emergency department admissions. And that the first 4 weeks in and out of OAT are higher risk periods for particularly higher risk periods. And then finally, we did work looking at whether or not there was an association between time spent in OAT and the extent to which people were charged. And this is looking at criminal charge rates for the date at which the potential offence occurred. What you can see going up these figures, this is having gone into treatment a higher number of times, so basically cycling in and out of treatment. The bottom here is people who only enter once. The top is people who'd entered 10 or more times. And on the bottom here, excuse me, is the amount of time that you were in the cohort for. How much of that time did you spend in OAT? So regardless of how many times you've gone in and out, how much of the time that you from when you first entered were you being retained in OAT? And what you can see is that the time that you spend in OAT matters. So the more time, so green is lower rates and red is higher rates. The more time you spend in OAT and the fewer number of episodes of time in which you spend that time are associated with much lower rates of offending. If you spend less time, and particularly if you cycle in and out of treatment, there are much higher rates of offending. And this is consistent with other work. It's quite a complicated relationship, but that does suggest an impact of OAT on engagement with offending. So just to summarise briefly, as I said in the beginning, the trends in opioid markets in Australia have some similarities to the US, but there are many differences. And hopefully, as I've presented here, we're really strongly of the view that data linkage can be used to examine and answer a really wide range of questions about treatment provision, service delivery, health harms of different populations, and exposure to different risk environments. It can also be used to investigate questions about potential impacts of treatments on a wide range of outcomes. And importantly, some of these could never be examined using more traditional randomized controlled trials. So for example, looking at mortality, trials are just not powered to be able to look at that outcome. And we're really excited about expanding this into other areas and to ask other important questions for different populations, different interventions, and other health, social, and economic outcomes. Thank you very much. So with that, I will stop sharing. And it is now my great pleasure to introduce Anik Borquez. Anik is an assistant adjunct professor at the University of California in San Diego, and fortunately for us, one of our conjoint researchers at NDARC, and it's been a pleasure to work with her over the past few years. Anik is a leading mathematical modeller in the drug and alcohol and infectious diseases field, and has really been doing some really important work across a number of areas, and she'll be presenting on some of that today. Thanks very much, Anik.
Thank you very much, Louisa, for that introduction and for presenting all the data that actually went into this model that we started working on a couple of years back. So very excited to be presenting the final results today. We used dynamic modeling to estimate the impact of the New South Wales OAT program on mortality. I'd like to acknowledge my co-authors at UCSD, in particular Antoine Chaillon, who carried out all of the modeling analysis that I'm presenting today, as well as Natasha Martin. I'd like to acknowledge the team at NDARC that did many statistical analysis to inform the model, especially Kriana Barat and Nikki Jones. And many thanks as well to our collaborators at the University of Bristol in the UK for all their input in the modeling. So I wanted to start with the motivation behind this work. Why did we decide to look retrospectively at the impact of the OAT program on mortality in New South Wales? Well, it is because while the individual level effectiveness of OAT in reducing mortality is very well established, as has been described by Luisa and by Thomas Santo during the poster session, we have I'm having to use this one. We have several meta-analyses that have been carried out and updated through the years, showing again and again that there is a very strong relationship here between OAT and mortality. However, the story is not the same when we look at population level impact of OAT in reducing mortality. There are limited data available, and their findings are mixed. Many of these come from ecological studies, and they have found, some of them have found positive associations and others have found negative associations. So there is a need for population level evidence of effectiveness, both to advocate for the scale up of OAT across settings globally that are in much need, including the United States, as we saw earlier on, but also to identify the characteristics or the features of these programs that actually lead to their effectiveness at population level. And dynamic model represents a very useful tool to actually investigate this question, as unlike statistical models that simply look at the association between exposure to treatment and mortality, with dynamic modeling, we're actually able to reproduce trajectories of drug use and trajectories of OAT engagement, and to understand what the mechanisms behind the mortality data are, and therefore to ask questions such as what is the impact of this program on mortality over a period of time. And as has been described in much detail by Luisa and poster presenters, there is very rich data in New South Wales to inform such a model. OAT was scaled up in the 1980s, and it has achieved a high coverage. It is estimated that about 40% of people who use opioids are on OAT at any one time. This is data from people who inject drugs, but we believe that it's probably very high among all people who use opioids in New South Wales. And as described, the OAT program has been linked to public data sets on mortality and incarceration. So rather than using aggregate data, we have individual data here to inform these models. And so it gives us an opportunity to develop a dynamic model reproducing this cohort of people who received OAT at least once between 2001 and 2018. The reason why we started the modeling work in 2001 is because the data for prisons, so the incarceration data, started being available from 2001. So, and we were very much interested in incorporating incarceration in the model, so that drove our decision there. I wanted to take you through the modeling structure first, so that you get an idea of how we represented OAT engagement and incarceration. We did this in quite a lot of detail for OAT engagement, because we wanted to be sure that we were represented the different periods of risk to be in agreement with the findings that have been presented through this meta-analysis. And so I'll take you, I'm gonna try to find a pointer, but let's see if I succeed. Here it is. So I hope you can see my pointer, but doesn't matter otherwise. So people start in the first month on OAT, and then they progress to a short OAT episode, which is up to 9 months, but can actually be much shorter. And they can drop out at this point and move into the first month of OAT. And after that first month, they will be off OAT for a longer period of time, and they can then start OAT again, a new episode of OAT. They can also progress into long OAT duration and then follow the same pathway. And we also considered people stopping opioid use, both in terms of illicit opioid use and in terms of treatment. And so they go into this no opioid use compartment, and the model considers relapse. And so people move into the off OAT for a long period of time compartment. And of course, they can join the first month on OAT compartment again. In terms of incarceration, we described 4 stages, being never or not incarcerated in the past year, and progression to currently incarcerated. progression to recently incarcerated under a month ago. So very important to represent this very high risk period for overdose during the first month post-release, and then transition into incarcerated in the past year, because we still saw residual increased risk of overdose death during this period. Of course, there can be re-incarceration during these 2 periods, and then people go back to this never or not past year incarcerated. Just to show you the effects that were implemented in the model, the baseline mortality is here for people who are off OAT over a long period of time, or longer than a month, I should say. And then we implemented a reduced risk of both overdose and other cause mortality for short and long duration on OAT. We implemented a reduced risk of mortality compared to baseline, so compared to off OAT during this first month, but not as important as past 1 month. As you've seen before, there is this slightly increased risk of death during this first month induction. And then we also incorporated this increased risk during the first month of OAT, so upon discontinuation. In terms of incarceration, we incorporated the increased risk of overdose and other cause mortality in the first month post-release, and a residual risk of overdose, but not other cause mortality in the first 11 months after that first month post-release. And we also incorporated this reduced risk of incarceration for those who are on OAT. I'm not going to go through all the parameters, but this was a very intensive process, and it required many statistical analyses that were primarily done on the New South Wales OAT program data, but we also used data from the published literature on mortality among people who use opioids, on the OAT effect on mortality through different periods of risk, and on the OAT effect in reducing incarceration, mostly from data in New South Wales for this last point. In terms of model calibration, we used approximate Bayesian computation, sequential Monte Carlo to minimize, basically to calibrate to the data. I'm not going to give detail about the method, but basically what we're doing here is that we're minimizing the sum of least squares between the model outputs and the data on several different data sets on OAT engagement, incarceration, and mortality. And you'll see how the model calibrates, so I won't describe this data in more detail just now. Now I'll move on to the scenario analysis. What did we investigate? We looked at 5 scenario analyses. First, a scenario that basically asked what would have happened had we had no OAT program between 2001 and 2020 in New South Wales. How many more deaths would we have had, or what proportion of overdose and other cause death were averted by this program in New South Wales? And to do this, we basically eliminated all of the effects associated with OAT on both mortality and incarceration. We then looked at a second scenario where we just focused on the OAT program in prison. So everything in the community stayed as observed. So there was OAT availability in the community, but we stopped enrollment in the prison. And for those who were already on OAT in prison, we moved them to the off OAT compartment. And so it meant that there was no OAT in prison. So everybody coming out of prison in that scenario came out of prison being off OAT. And a third scenario in which we were very much interested in better estimating the impact of this first month post-release on mortality. So identifying or estimating the population attributable fraction of this first month post-release. And finally, the last 2 scenarios were more to do with OAT program effectiveness and how to potentially improve it by looking at these periods of increased risk. So firstly, estimating the population attributable fraction of the first month of induction. What would happen if there was no increased risk? Of course, this is an extreme assumption, and it's just to give us a range of what is the contribution of this, the maximum contribution that could be eliminated if we had proper interventions during this period. And we did the same thing for the first month of OAT, so for the discontinuation period. What is a population attributable fraction of this period for both overdose and other cause deaths? This is just to show you that the model calibrates well to the data in terms of total population, individuals on OAT in prison, out of prison, proportion currently incarcerated in the cohort, proportion ever incarcerated. We really struggled with this one, and that's the best we could do. But it also fits well to data on mortality. So total deaths, overdose related death, death from other causes. And here you have, it's a bit repetitive, but proportion of overdose related death, and proportion of overdose related death that happen while on OAT. I'll move on to the results. These are not outputs from the model, these are outputs from the cohort, but I wanted you to get an idea of which cohort we were representing and which data came into the modeling. So there were over 49,000 people in the cohort represented in our model between 2001 and 2018. An average of around 17,000 were receiving OAT at any one time. So that means that between 47 and 66% of the cohort were on OAT at any one time across those years. On average, individuals had 3.7 OAT episodes over that period for a mean duration of 1.74 years. But of course, there was a wide variation in duration of the episodes from 1 day to 17.4 years. So just to acknowledge this variation. In terms of incarceration, between 2001 and 2018, I mean 7.3% of the cohort were in prison at any one time, so currently incarcerated, and 23% had been incarcerated in the past year, so had been in prison, but were out of prison at that point in time. And in terms of mortality, we observed over 5,000 deaths, of which 1,500 were overdose-related deaths. I'll move on to the results. And so here I'm showing results for our two first scenarios, the impact of the OAT program. So you can see here that over 53% of overdose deaths were averted by the OAT program, according to our estimates between 2001 and 2020, and 27% of other cause deaths. If we only look at the OAT program in prison, this averted 12% of overdose deaths and 5% of other cause deaths. And moving on to the contribution of this first month post-release, we found that about 4% of all overdose deaths over that period are attributable to this high-risk period, and a very small number of other cause deaths. I want to highlight here again that we're looking at a setting with very high OAT availability in the community. So for many of these people, once they came out of prison, they were able to re-engage in OAT. So it would be different had we not had this high coverage of OAT in the community. In terms of the potential for increased program efficiency, if we were able to eliminate the risks associated with this induction period, an additional 2% of overdose death could be eliminated or avoided, and 1% of other cause deaths. And in terms of this discontinuation period, the risks are higher. So 4% of overdose death could have been averted, and 3% of other cause death. So quite an important contribution of this period, given that it's such a short period in comparison to the full time on OAT that people go through. So the model, of course, has limitations. Firstly, this analysis is restricted to the cohort of people who received OAT. So we're not representing the full population of people who use opioids. There is uncertainty in model parameters, as with any mathematical model, especially we have less certainty about the OAT treatment end dates compared to the start dates, and we didn't have data on death outside of New South Wales from 2010 to 2018. So we had to infer from the previous years. We did not account for differences in OAT severity or mode of administration, so injected versus not. We also did not explicitly simulate differences by OAT modality, so we were not differentiating methadone and buprenorphine or dosage. And we very much focused on mortality. So we did not incorporate the reduced risk of HIV and HCV infection while on OAT, reductions in morbidity, increased well-being, and societal impacts through increased productivity, crime reduction, improvements in the well-being of family and friends. So there's many other benefits of OAT that are not being represented here. And finally, this is not necessarily generalizable to all other OAT programs, as they will have different characteristics, but it shows the impact that can be achieved when a high coverage is achieved. So in conclusion, the OAT program in New South Wales has averted over half of overdose death among clients receiving OAT between 2001 and 2020, and a third of other cause deaths among this cohort. This represents over 33,000 life years, and it corresponds to nearly 10 life years gained per 100 person years on OAT. 12% of all deaths averted by the program were averted by the prison OAT program. So strong contribution there, suggesting that this needs to be maintained at high levels. And a key feature explaining these results is probably the long average duration of OAT episodes in New South Wales compared to other settings such as the UK. And finally, if we just focus on the OAT program, there is potential for increased effectiveness through interventions to reduce risk upon OAT induction and discontinuation, as well as over the first month post-release from prison. And I don't have time left, but I basically wanted to say a big thank you to the team at NDARC that treated us really well while we were out there. Thank you to Louisa and to Michael and to Sarah, and it was great spending time there. Thank you to Professor Andrew Lloyd, who took us to the prison, to the Curtin Road Center, who showed us the services that they provided to people who use drugs, to NUA as well for showing us their syringe services programs, to the safe injection, I was going to say room, but it's not room. I can't remember what it is, but for showing us the services they provide, and to Jill Roberts and Robert Conalaglan for talking to us about the methadone program in the prison, well, methadone and buprenorphine. And of course, all of the funders, as this wouldn't be possible without support. And thank you very much for listening.
Thank you very much, Anique. Just a reminder to people to do send through any questions that you have for Anique. I'm just about to introduce our final speaker, and then we'll be having a question session. So please send through any thoughts or questions you have while they're fresh in your mind. So I'd now like to introduce Dr. Natasha Gisev. She's a scientific fellow at NDARC and has been working for a long time using linked data sets, particularly focusing around different questions around different pharmacoepidemiological questions. And she's going to be presenting today on the POPI2 project. So over to you, Natasha.
Thank you, Louisa, and good morning, everyone. So I think earlier Louisa did touch on some of the power of using data linkage studies. For those of you who have done data linkage studies before, you would know that there's a lot of lead time and planning that goes into these studies. So this is a study that Louisa and I have been working up for a while now with our colleague Sally Pearson at the Centre for Big Data Research in Health. And yeah, really pleased to be able to share some of the initial findings with you today. So as we've heard earlier this morning, Australia is one of the countries that has observed significant growth in opioid prescribing over the last 30 years, as well as an increase in a number of different opioid-related harms, including things such as falls, injuries, dependence, non-fatal and fatal overdose. Opioids do, however, play a really important role in pain management. There is a tension, though, in facilitating better pain management and managing the risks of inappropriate prescribing. Currently in Australia, there's a lack of population-based level evidence about the drivers of long-term prescribed opioid use, dependence, overdose, and other harms. Most of the data that we have available in the public domain tend to be derived from ecological studies, and no study as yet has nationally linked individual level data on prescription opioid use to health outcomes. So to fill this gap and build an evidence base on the outcomes of prescription opioid use, we built a program of work that uses linked data to understand patterns and characteristics of opioid utilisation in detail, to quantify the risks of adverse outcomes associated with opioid use, and to examine the population impact of changes in opioid regulation and policy. To do this, we designed a retrospective population-based cohort study. So this consists of all adult New South Wales residents who initiated a prescription opioid between 2003 and 2018, representing a total of 3.57 million people. The cohort was then linked to a number of other different data sets containing information on sociodemographic and clinical characteristics, health service use, as well as a range of different health outcomes. So the data sets and linkage process are summarised here. So as you can see on the left, the cohort was defined using pharmaceutical benefit scheme records. So this means that we have information on all their opioid dispensings and information on their other medicines that are subsidised by the pharmaceutical benefit scheme. And through probabilistic linkage, the Australian Institute of Health and Welfare and the New South Wales Centre for Health Record Linkage were able to match and extract data on cancer notifications, death records, as well as a range of different health service use, including things such as GP visits, inpatient admissions and ED presentations to New South Wales hospitals, as well as some more specialised mental health and opioid dependence treatment. For those interested in knowing more about the methods for the study, the detailed protocol has been published in BMJ Open and can be found online. So as you might have guessed from the size of the cohort and the number of data sets we have available, we've had a lot of information to work through to really get an idea of what the actual profile of the cohort looks like. The findings have been submitted to a journal for publication, and today I'm going to give you a first view of what some of the key highlights are of the characteristics. So looking first at the type of opioid initiated by the cohort. So this graph shows the most commonly dispensed opioids were paracetamol codeine combinations, with 61% of the cohort initiating or entering into the cohort using this medicine. Oxycodone was initiated by 16% of the cohort and tramadol 11%. Overall, less than a third of the cohort were dispensed a strong opioid at the time of initiation. So these are things such as oxycodone, buprenorphine, morphine, and fentanyl. And these patterns are reflective of what we know about opioid use in general across Australia. In terms of the socio-demographic characteristics of the cohort, so there was almost an even split between males and females. Over 70% were aged 35 years and over, with 12% aged 75 years and over at the time of cohort entry. The majority resided in a major city, and approximately half were dispensed an opioid as a concessional beneficiary, which is a marker of potential socioeconomic disadvantage. In terms of other medications, other medical conditions, so 6% were identified to have cancer in the year prior to cohort entry, with 17% having depression. And this is consistent with the literature identifying high levels of comorbidity between depression and cancer conditions, particularly chronic non-cancer pain. Less than 1% of the cohort had a prior opioid use disorder, while 2% had another substance use disorder, which can potentially be a risk factor for later developing an opioid use disorder from longer-term opioid use. In terms of the other analgesic and psychotropic medicines used by the cohort in the 3 months prior to cohort entry, so 11% of the cohort used other non-opioid analgesics, so this includes things such as paracetamol and pregabalin. 19% used non-steroidal anti-inflammatory drugs, so things such as ibuprofen and celecoxib, while we do have a small proportion of the cohort who are using anti-epileptics, and some of these medicines are often indicated to manage conditions such as neuropathic pain. And 4% of the cohort used sedative hypnotics, including benzodiazepines, which obviously we know that using these medicines may potentially be a risk factor for adverse events when used together with opioids. So in summary, we have 3.57 million people who initiated a prescription opioid in New South Wales over the 16-year period between 2003 and 2018. When we compare some of the socio-demographic characteristics of our cohort, so looking at things specifically such as age, sex, and regionality, the distribution of these characteristics are broadly similar to the general New South Wales population, which does highlight the representativeness of our cohort. However, a point of difference is that our cohort does have a more complex clinical profile and extensive medicine and health service use. Overall, these findings provide us with really important baseline information that will inform the basis for future studies arising from this cohort. So building now on what we know about the profile of the cohort at the time of opioid initiation, the second piece of work we've undertaken is exploring the trajectories of opioid use in the first 5 years following initiation and examining the individual characteristics associated with different trajectories of use. So the reason why we wanted to look at 5-year use trajectories is because there is a particular concern about long-term use of opioids in clinical practice, particularly among people with chronic non-cancer pain, as the evidence currently suggests that the benefits of use may not outweigh the potential harms. However, currently in Australia, we really don't have a lot of information about what happens after someone starts a prescription opioid for the first time. So these findings are hot off the press. Using a technique called group-based trajectory modelling, we identified 5 distinct trajectories of opioid use in the 5 years following each person's opioid initiation. So from top to bottom, these are sustained use in yellow, moderate decreasing to low use in grey, low increasing to moderate use in green, low use in blue, and very low use in burgundy at the bottom there. Overall, most individuals had relatively low use of opioids over the 5-year period. And as we can see, 3% had increasing use, while 3% had sustained use. In terms of the individual profiles of each of these groups, so the heat map on the right shows the relative prevalence of a range of baseline characteristics for each of the 5 trajectories. So areas shown in darker blue indicate a lower prevalence of a given characteristic, while those shown in darker red indicate a higher prevalence. And in summary, individuals with sustained or increasing opioid use trajectories tended to be older, with more comorbidities and hospitalizations prior to opioid initiation, and had higher rates of other psychotropic and analgesic medicine use, and were also initiated on stronger opioids and at higher doses. So although most individuals had relatively low use of opioids, these findings do show that individuals with sustained or increasing use do tend to have more complex clinical profiles. So opioid use in this group is really likely to reflect a higher prevalence of pain and treatment needs in these individuals. So understanding these use patterns is the first step for us in being able to explore some of the rates of harms among each of these groups, with the ultimate goal of informing potential mechanisms to prevent harms from long-term opioid use. So I do want to flag that we have a number of people working on the project at the moment, and several studies are in progress with many others planned. So some of these are summarised here. So at the moment, we're finishing work defining methods for estimating opioid exposure and how best to do this using pharmaceutical benefit scheme data. We're preparing a number of different exposure outcome studies to specifically look at the relationship between using a prescription opioid and the risks of non-fatal overdose, fatal overdose, and transition to opioid dependence. We're also taking a look at some of the prescriber level variation in opioid use, and exploring some of the use and outcomes in some specific populations of interest, so including older adults, those with cancer, and those with a history of opioid dependence. So to finish today, I want to highlight the potential impact of this work. So obviously with a cohort of our size and the number of data sets that we have linked, the POPI2 study is one of the most comprehensive post-marketing surveillance studies of prescription opioids in Australia at the moment, and one of the largest studies worldwide. So we have uniquely linked opioid exposure to outcomes and are able to examine risk factors for adverse outcomes of a number of different prescribed opioids. The population-based cohort design means that findings are highly generalisable, and we do expect that over time, findings will inform policy and practice, and particularly with regards to developing individual and population-level interventions to reduce harm. So I would like to acknowledge our funder for this work, the National Health and Medical Research Council, as well as all the data custodians, the AHW and Cheryl for providing us with access to the linked data, and of course the large team of people listed here that we have working across the project. So thanks so much for your attention today, and looking forward to answering your questions shortly.
Thank you very much, Natasha, Louisa, and Anik for fascinating presentations. Louisa, I'll let you kick off. We don't have any questions, so if people have questions, if they could put them in the Q&A so that we could actually, and we will try and respond to them. First of all, Lucy, do you have any comment on Anik or Natasha's presentation?
Yeah, I mean, I think firstly, you know, Anik's work, we're really pleased with that work. We think it's a really important potential piece of evidence that, you know, mathematical modelling is fantastic, but it's best when it's actually based on data rather than things that we think might be the case. And I think that's really the strength of this mathematical model, which means, I think, in terms of having evidence for advocacy for scale up of OAT in other places, but also starting to think about where might there be opportunity for tweaking things that are happening in New South Wales so that we can improve things even further. That's the hope for this kind of work.
Great. And then with Natasha's 3% of people, I think that recent, just hot off the press stuff is fascinating, that the majority seem to be actually at minimal risk. So how do we figure that out in relation to future advice around prescribing? Because I read it as that the majority of people actually seem to have minimal problems with opiate prescribing.
Yeah, and I think that's a really important finding from what Natasha was presenting, that there's so much concern around, I guess, the group of people for whom opioids become something that is a long-term thing, but it's obviously the case that most people might get an opioid prescription and then not have another one. So I think it's a really, and that's one of the benefits of POPI, because we've got the jurisdiction-wide coverage, that you can really put kind of parameters around the scale of different things that people are happening that you are very concerned about clinically, but at the population level, getting a sense of how commonly are those kinds of patterns occurring.
Okay, so the question for you, Anik, is where do you go next with this type of work? What's the next phase of this type of work?
Thank you, Michael, for that question. Well, the next phase is, now that we've been able to reproduce historical patterns of both OAT engagement and mortality, the plan is to look into the future and project the potential impact of the OAT program in the future, looking at different scenarios in order to identify how best to optimize the delivery of this intervention. In particular, disaggregating the model by drug, so buprenorphine versus methadone, to identify how best to allocate these two treatments to different types of patients. that's what we're thinking at the moment.
Okay, and I think it's worth emphasizing that the importance of this modeling is, as you have said, that it demonstrates at a population level major impact of opiate agonist treatment, and that really is pretty much a world first. And I think we're also able to announce that this is actually just accepted for publication in the last day or so. So that's very good. So over to you, Natasha, in relation to, you've talked about where the future work, what's your hope for the greatest impact of this data set?
It's really hard to answer, Michael, because I think we've got so many ideas, and I know it's like my list of paper ideas builds every single day. So I think, yeah, I'm really excited by the project. I think we are obviously in a really unique position to be really able to help sort of build that evidence base around opioid use and outcomes. So I guess, you know, overall, I guess my hope for this project would really be able to, you know, in terms of particularly around our exposure outcome studies, to really help drive some of the policy and practice change.
And that impacting on policy and practice change will involve extensive consultation with stakeholders, both federally and nationally. Louisa, you presented a very broad overview of 10 years of work. And where do you see machine learning or other new technologies coming into the next phase of this work?
Yeah, I mean, we've got, so I think I mentioned some of Kriana Bharat's work. She's looking at using machine learning for these kinds of linked data sets to see if you can utilize that kind of technology to predict who is at greater risk of different outcomes. I think it's a really important potential technology. You know, one of the things is that Kriana and I were actually talking about earlier in the week is that whole concept of, you know, what you find works in one particular setting, is it going to be relevant in another? And so that's going to be a real thing to focus on in terms of validating the predictive modelling that definitely Kriana is focusing on at the moment. The other thing, though, I think that we want to do here is to actually say, well, what other kinds of very different populations can we actually apply these linked data analysis studies to answer other kinds of questions that are hopefully relevant clinically and policy-wise.
Thanks, Louisa. So a question from Lee for Anik, but Louisa, either of you might answer it. He wants to know, could you do similar work for other parts of Australia or other parts of the world? So you can answer for other parts of Australia, Louisa, and then Anik can talk about other parts of the world.
Sure. So thanks, Lee. So the short answer is there is some work in Western Australia that is undertaken using linked data to analyse OAT outcomes. But in most other jurisdictions, it's just because of the vagaries of how the data are collected, it's largely the potential is much more limited, is what I understand, and I'm not aware of other work in those states.
Anik?
Yes, thank you for that question. Well, actually, some of the work that we had planned to do, and we thought a small supplement from NIDA, was to look at what data would be needed to carry out a similar analysis in the US, maybe not at national level, but at least in specific states that have better data. The issue at the moment is that there is no such linkage of data in the US, so it wouldn't be as high quality data, but there's still approximations that we could make based on what's available. So that would be the next step.
So one of the points I think that is important is the reason New South Wales has been used is because of the nature of the data set, particularly the registration data set for OAT treatment. It has enabled these studies, which it's harder to conduct in other states for that very reason.
Yeah.
The other question, and Ian has asked about the prisons, he says that in his experience there's more methamphetamine use, and is there an approach to doing more work on intravenous use and methamphetamine use in the prison, Louisa?
Yeah, I think it's a really good observation, Ian. And yeah, we are very aware that there's a lot of people who are going to prison who might also have been using methamphetamine, whether or not it's related, obviously not commenting on that. But yeah, we are interested in looking at that issue. It's a bit more difficult to look at methamphetamine use using linked data sets, but it's definitely something that we're interested in pursuing.
So Lee asks, is there any work on the standardization of how data is collected? Maybe we'll get Natasha to talk about that even.
I think there's definitely interest in doing it, and I think everyone does sort of acknowledge that we do need to kind of be reviewing how these data are collected and even the level of detail. So I think even with some of the work that we've done with that, the opioid dependence data set, there is only so much you can do, I guess, when you are using routinely collected data. So I guess the short answer is yes, but probably a work in progress.
Well, look, I would like to thank everybody. I'd like to thank our speakers for a fascinating seminar looking at global issues and looking at data sets and presenting really important, globally relevant information. I'd like to thank you, Anik, for zooming in from the West Coast of the States. And I'd like to thank all our listeners for sticking with us. I'd like to apologize for some of the technical difficulties at the very beginning, but some of them are unavoidable. We may try and see if we can have David's talk re-recorded and put online, but we look to try and do that. And I would like to thank everybody today and invite people for the meeting tomorrow, where we will be talking about the results from drug trends and looking at the implications of that for other aspects. And if you haven't already registered, I suggest I'd encourage you to log on to the NDARC website and to register. And I'd like you to have a good rest of the day and look forward to you joining us tomorrow. So thanks everybody, and goodbye and take care. Stay safe.